And so with that, I'm going to introduce Dr. Mark Katz. He is a urologist. He's going to be talking with you today about bladder cancer. He sees these patients, he operates on them, and he'd be a great person for you to talk about. And I'm looking forward to your questions. Dr. Katz.
Thank you. Good afternoon, everybody. Thanks for having me come and speak today. It's a real honor. I work at Boston Medical Center with Dr. Rosen and several of the other speakers that you're going to have today. And we're going to be talking about bladder cancer today. This is an outline of what we're going to talk about. We're going to talk a lot about the basics of bladder cancer, just because I'm not sure about everybody's background. We'll go into some of the diagnostic things that we do, some of the treatment options, including the surgery that we do, different systemic therapies like chemotherapy. We're going to talk about robotics, where I think there's a lot of research applications and possible collaborations. Anywhere along the way where I think there may be some type of collaboration we can do from a biomedical perspective, I'll try to pause for a minute and see if we can kind of highlight that. We'll talk about some of the concepts of the surgery that we do, including how we reroute the urine when we do some of these complicated surgeries called urinary diversion. We'll talk about disease that's already spread outside of the bladder, and surgery is not a good option anymore, and we don't do very well with that. So we'll talk about some of the future options we can do with that, and then we'll try to wrap things up. So I put this up because, to me, bladder cancer is the big elephant in the room. It's the 5th most common cancer, 4th in men, 8th in women, extremely lethal at certain stages. But you don't hear a lot about, like, the marathon for bladder cancer, or like, let's wear our bladder cancer pin today. There's no bladder cancer pins over there, I can guarantee you that. So to me, I feel like it's something that's the knowledge in the public perspective and in the marketing perspective is somewhat low, and it's a really devastating disease, and actually per patient the most expensive cancer to treat, because some of the ways and some of the techniques that we use in the office to diagnose and treat it are extremely expensive, and there's certainly plenty of research opportunities to try to fix that from an economic perspective. Obama might like that. Okay. So again, I said some of the stuff about the statistics. It's the 5th most common overall, 4th and 8th in men and women. It is more common in men, and it's more common in Caucasians, and it does tend to be a disease of the elderly. So these are people in their 60s and 70s that are coming into our office. I'll tell you about the symptoms that they have. About 70,000 estimated cases in the US and about 15,000 deaths, and that was last year. Females tend to have a larger delay in the diagnosis because, as we'll talk about, one of the major symptoms is blood in the urine. When a guy has blood in the urine, it's pretty dramatic. But a lot of times when women have blood in the urine or urinary tract infections, or there's, it gets confused with their menstrual cycles, et cetera, there tends to be a delay in diagnosis. So what you'll see is sometimes we'll even catch these cancers later in women, which is not good. So definitely some research opportunities on this front. And this is just a paper that highlights there's also racial differences. So there's a higher hazard of death from bladder cancer among women and also African Americans. So we need to further look into the genetics of this. And there's very little research that's been done on that in bladder cancer, plenty in prostate cancer, but much less in bladder cancer. Now, when we talk about bladder cancer, we want to talk about the cell of origin, and what's the cell we're talking about. So for most cancers, and for what this lecture is really talking about, it's the transitional cell, which is the lining of the bladder. It's the inner cells that line the bladder that the urine bathes in. These are the cells we're talking about. The squamous cell, the adenocarcinoma, and the small cell carcinoma are very rare birds that we're not going to really focus on today. So we're going to focus mostly on urothelial cancers, cancers that line the bladder. This is what they look like when you go inside with the telescope, and we'll talk about the diagnostics. A lot of them look like these little flowering lesions. Here's a little picture of the normal bladder lining, and then, not too subtle. I picked ones that were obviously very easy, but sometimes they can look very different. And these are some of the risk factors. Number 1, 2, and 3 is smoking, very similar to lung cancer. So the patients actually are very similar epidemiologically to lung cancer patients. Heavy smokers, working in industry, getting exposed to some of these rare dyes, elderly, blood in the urine. Again, especially for women that are having a lot of urinary symptoms that aren't explained by infections and you can't figure out why, you got to think, could there be something else going on? I highlight this because we've been doing a lot of radiation for malignancies. So there's a new literature now out there that some cancers develop after radiation, a delayed time down the road. So people that are getting radiation for prostate cancer, cervical cancer, rectal cancers, because the bladder is in that area, if there's some unintentional radiation that's going to it, we found that there is a slightly increase of bladder cancer down the road 5 and 10 years. So something too important to look at. Again, so how they present. Blood in the urine, which we call hematuria. It can either be visible or microscopic. The urinary symptoms, especially in women, and then when it's already spread and become a real problem to treat, you talk about symptoms of cancer that are more generalized, like abdominal pain, weight loss, damage to the kidneys from blockage of urine, things like that. The staging is how deep the tumor goes into the bladder wall, and that really affects how we treat it. So these ones that don't go so deeply, we call them non-muscle invasive, and the real dividing line is the muscle wall in the bladder. This big red area here is the muscle wall. This is the inner lining. So once the tumors get to this stage and their tentacles kind of come into the muscular wall, that's when the risk of spread and death from bladder cancer becomes much more significant. These are much easier to treat and tend to be less lethal, whereas these are the ones that tend to be more problematic, and because they have much more access to the bloodstream and the lymphatic channels, this is when they can spread to other parts of the body. So the stage of presentation, about 70%, thank God, occur in the non-muscle variety, which is the less lethal. Unfortunately, about 30% or more of patients present already when the disease is into that muscular lining or even further beyond. And these are the ones that really need the help as quick as possible. And we'll focus a lot of our talk on these patients, but a little bit on these as well. The grading is what the cells look like under the microscope. So it's not the stage, but it's how bizarre do the cells look. Do they look similar to a normal cell, or are they completely off the wall and just completely abnormal? Tumors that we call low grade look more like normal cells. Tumors that are high grade are the much more bizarre ones, and these are the ones that tend to be the deadly tumors. And bladder cancer really goes on a two-track system. The low grade tumors and the high grade tumors are very different from a genetic perspective. It's almost two different cancers. These ones that develop into the low grade that have a chromosome 9 issue, they tend to be more just like nuisance polyps. They cause bleeding. They need to be continually removed, but they rarely penetrate deeper and cause death. Whereas these that have more cell cycle abnormalities with P53, RB, and P16, these are the ones that tend to be bad actors from the start. So it's really two separate cancers. It's our job as clinicians to try to figure out which ones they are and then tailor our treatment accordingly. And this is just an example. So this is a low-grade tumor. You can see that all the cells, these blue things, they look kind of more similar to each other. This is a high-grade tumor. Everybody's out of whack. You got big ones, small ones, stuck together, separated. So it's not too subtle under the microscope in terms of which ones have more of a potential to grow and spread. So how do we diagnose bladder cancer? It's typically first a visual diagnosis and then a pathologic diagnosis. We take a little piece and send it to the laboratory. We use a little flexible endoscopic instrument called a cystoscope, which is like any other endoscope like you would have for your colonoscopy or for a bronchoscopy to look in the lungs. It's got a camera at the end. It can either be fiber optic or digital. We can do them in the office with this looks fun, right? We can do it in the office with the flexible scope, which is a little bit less painful, or you can do it in the operating room under anesthesia, where the equipment tends to be larger, kind of like a baseball bat. No, just kidding. And so we look in. Visually, this really looks like a tumor. Eventually, it would need a biopsy to confirm it. That's done under anesthesia. That's the main way we diagnose bladder cancer. There are some new ways in the last 5 or 10 years that we've tried to become more accurate, because you can see that the pictures I've been showing you are very obvious tumors. But would this be a tumor, or would this little red area be a tumor? We never were really sure. So we were taking everybody to the operating room to biopsy it to check. But we've come up with some fluorescent techniques where we can inject a liquid into the bladder that will fluoresce under different wavelengths of light, and then all of a sudden, this becomes quite obvious that it's abnormal. The blue light is the normal, and then these are the tumors that were much more subtle here. So this is one way we're trying to become a little bit more cost effective because the amount of endoscopies and biopsies is so high, and that's why I go back to my introduction where bladder cancer is one of the most expensive cancers. A lot of it has to do with the diagnostics that we're doing, where a lot of these invasive procedures cost a lot of money. So although it's a little bit more cumbersome because you have to put a fluid in, you have to get the different wavelengths of the light, you get a lot more bang for your buck with the fluorescence. And certainly there's a research opportunity here to try to continue and refine these diagnostics to make it more cost effective and less invasive for the patient. Something to think about. When patients urinate, what we can do is we can collect the urine sample, spin it down in a centrifuge, and look at the cells individually. This is a much less invasive, unfortunately not quite as reliable way. We call this a cytology. And you can look at the cells, and you have a specialized pathologist that deals with this and can tell you that these are malignant cells or not malignant cells. Not nearly as reliable as direct visualization and biopsy, but definitely an adjunct that we use to help diagnose bladder cancer. Let's move into the treatment a little bit. So for those tumors that don't invade into the muscular lining, where we don't need to be as aggressive, we take this instrument, which is similar to the flexible one in the office, but this is more like the baseball bat version. We go in, and there's a little scraper on the end of it where we can take that piece out, like this, take the piece out, send it to the laboratory, and they tell us what it is. They can tell us how deep it goes into the lining. They can tell us the grade of it. Does it look very bizarre? Does it look normal? And then based on that, we can say, okay, he needs further treatment, or you know what, we think we got it all out. Let's just follow him and see how he does in the future. We always want to make sure that we get enough depth of tissue here so that when we send it to the pathologist, they can tell us, okay, we saw the muscle lining, there was no tumor in there, so we know it's just a lower tumor, or it does go in there. So a lot of technology that goes into these instruments, always being refined with different types of unipolar, bipolar energy, different wavelengths of lasers that people are using now to do this. So this is definitely something that's on the forefront of biomedical research. Intravesical therapy is something that we use for patients that don't have the deeper tumors, but we want to help prevent them from coming back. It's actually in an attenuated form of the tuberculosis virus that 30 or 40 years ago, by accident, they found out that people that were getting vaccinated for TB were getting less bladder cancer. So then, 20, 30 years later, all the research gets done. This ends up ramping up your immune system, the T1 cell helper pathway, and it ends up decreasing recurrence and progression. So people that are at higher risk for it coming back, we instill this into their bladder as a liquid for 6 treatments in the office, and then continuously over the years we'll do little maintenance for them, which is nice. Similarly, you can put chemotherapies in the bladder as well to help tumor reimplantation from occurring, et cetera. So these are adjuncts. They don't work by themselves. The tumors have to be removed, but then they help afterwards. Once the tumor's gotten into the muscle, the treatment also gets much more aggressive. You have to usually remove the bladder completely, reroute the urine another way so it can be exited out the body. So it becomes a much more morbid treatment for the patient. In the male, that includes taking out the bladder, the prostate, the lymph nodes that surround the bladder, and then rerouting the urine. In the female, it includes the bladder, the uterus, tubes, ovaries, part of the vaginal wall, the lymph nodes, and rerouting the urine. So this becomes much more major. So the stakes are a lot higher. It's a much more lethal tumor at this point, and it's also much more morbid for the patient. So you can see how the diagnosis is really important, because you don't want to get that wrong, that it's in the muscle wall or it's not, because the treatment goes from a little scrape to this. So there's a lot of area on focusing on research on the diagnostic aspect of it. This is just the largest paper on the results. It was about 10 years ago, believe it or not already, but about 60 to 70% of these patients don't have disease after 5 and 10 years, all comers, depending on their pathology. A lot of them end up getting some chemotherapy as well. So the results are good. They're not great. I'm not going to have you read this, but basically it can get as high as 85% and 82%, which you see here, depending on the final stage. So what I tell patients is, if we take it out, up to an 80 to 85% chance that at 5 years there's going to be no tumor there, is basically what I tell them. We typically do that surgery with an incision. Obviously, the bladder incision would be down here. This is an upper abdominal incision, but I put this up to say that the forefront is now moving towards minimally invasive surgery using smaller keyholes to achieve the same result. Whereas a typical bladder cancer incision would go from about here, around the belly button, down to about here. So the next phase, which has been really actually just in the last few years, has been to use the Da Vinci robot to take out the bladder cancer. This is a picture of where the surgeon sits. This is a picture of the device that interfaces with the patient. These are the 4 arms that are inserted into the abdomen through little 1 centimeter openings. And what it's done for us is it not only helps the patient recover faster, go home faster, but they also lose less blood, there's less morbidity, their bowels wake up faster, which is one of the biggest things about bladder cancer surgery, because you have to reroute the urine so their bowels slow down. So this has been a really great tool. Only a few centers have done more than 50. Probably, I can count them on one hand now. This slide's a little old. There's probably 2 or 3 more. BMC is on the forefront. We've probably done double digits, but certainly not 50 with the Da Vinci. And this is what the incisions look like when you do the surgery with the Da Vinci. It's usually 5 or 6 small little slits here. This is how this instrument that you put in mimics the human wrist. So one of the limitations of laparoscopic surgery, which is keyhole surgery, is that you were pretty much just putting in these things that look like chopsticks, but they didn't have any motion in the wrist. So this thing actually completely mimics a human wrist and lets you do all the things that your wrist would do, which is extremely important. I think I have a few videos here. This is just to quickly show what it looks like. So this is on the inside. Oh wait, it's showing up here, but it's not showing up there. That's interesting. It just, I'm seeing it here, but I'm not seeing it there. Is the AV guy here? That's a bummer. Yeah, it looks, could it be the light, you think, or?
It's not adjusted to it. Yeah, the light won't show it. You're gonna have to move on.
Okay, no problem. Well, I'm sorry that you can't see the videos, but if anybody wants to come up here afterwards, well, maybe this one will work, okay. These are quick little 30-second clips here. So this is inside using the needle to stitch up a certain part. And these are the 2 arms of the robot that are actually putting in the stitch here, which is this needle. And now this left hand is going to grab it. And you can see that you can kind of sneak into small little crevices that your hands would never be able to get into. And for urologic surgery, which a lot of it is done in the deep pelvis area, this is really crucial. You can see this just shows how you can tie a knot with the 2 hands. And you'll notice how these 2 things, well, that's it, but just a quick picture of how you can tie a knot with it. So it's quite helpful. The size what? It's about 1 centimeter in diameter, the whole thing. It comes in as like a tubular instrument, kind of like the diameter of this microphone, and then the whole grasper is probably 1 centimeter in size. So you can really get into much smaller places. Okay, so what about after you take the bladder out, how do you eliminate the urine? That's the big deal. So virtually all techniques that we use today utilize the intestine as a substitute to help eliminate the urine out of the body. We've been doing this for over 100 years, and it's essentially not changed. So this is definitely a huge area of research right now to come up with additional techniques to try to replace what we're doing for the intestine. I'll quickly show you a couple of the techniques. One is that we use a little piece of the intestine and just bring it out to the skin right here. This is called a ileal conduit. So the patient wears a little bag like this, and the urine just goes into the bag continuously. Every 6 hours or so, you empty the bag. And it's covered by the shirt completely, but it's not what we call continent. It doesn't have control. It's just always emptying. So there are other ways that you can do it called continent diversions. One way is that you just have to put a little catheter into this little red dot right here on the abdomen every 6 hours and empty the urine out of the reservoir. So it's just every 6 hours. You go to the bathroom, you slide the catheter in, the urine comes out, you take the catheter out, you're done. But you don't need to wear a bag. You can just put a little Band-Aid over this. And the final way is actually you can connect this spherical bladder made out of intestine right back to the urethra and reconnect it completely. So that's called the Neo-Bladder. You make a spherical bladder out of the intestine, connect it back where the old bladder was, and you actually pee out the same way. We do that in younger, healthier patients that are going to live longer, that don't want anything on the outside. These are extensive operations. They take 4, 5, 6, 7, 8 hours, a lot of morbidity, and most of the complications of bladder cancer surgery occur from this part. The quality of life is improving, our surgical technique is improving, but still, it's a major limitation. This is, again, just to highlight complications. It's not a great thing to do. They get a lot of metabolic issues, vitamin deficiencies, and then all the things that we have to sew back together. A lot of places can get strictured and narrowed and cause scar, and then they need to be fixed. So this is what we talked about. There are several challenges that we've come up to try to create an alternative replacement. One is, can we create a good biodegradable scaffold so we can bring in normal cells of the bladder, transplant them in, and have them grow into essentially an organ in vitro and in vivo. There's a lot of issues with that: tissue rejection, scarring, the potential of the cultured cells that you put back in to become cancerous because you're taking it from the same organ, et cetera. But nonetheless, this is a big area of research, and there's a whole field called bladder regeneration, where we're actually taking tissue from either fat cells or from bladder cells. We're growing it on a biodegradable construct, usually made of collagen or polyglycolic acid. You grow it in the lab for 6 to 8 weeks, and then you actually implant it back into the patient. And this is actually being done in humans already. This is called the Neo-urinary conduit. It's that same tube where somebody would wear a bag, but instead of actually using the intestine, this is cultured cells that eventually develop into urinary cells. They line the tube, and then you sew everything to this so you don't have to touch the intestine at all. 4 have been done in the US to date with pretty good success. And actually, they're able to culture the fat cells, which are more kind of, can develop into any other type of cell in the future. So they've actually been able to avoid having to use the bladder cells, which could become cancerous because you're taking it from a cancerous organ, essentially. So this is something that's really big right now, bladder regeneration. This is in vitro now, them trying to make a bladder completely, not just the tube. And again, the scaffold right here. So this is something that's in preclinical trials, but something where significant research and collaboration could be a potential. And finally, just 2 slides on cancer that has now spread beyond the bladder. I want to leave you with this because this is, again, something that we're not good at. And I think it's important to highlight the things that we're not good at because that's where we can collaborate. When cancer is already spread beyond and you need to use chemotherapy agents to try to kill it, we don't do well with bladder cancer. There's almost no long-term survivors at that point. You can get what we call a complete response, but it's very short. And usually by 14 to 16 months, it's already come back. And again, this is a field that, and here's just a curve saying that, you know, by 3 years, almost everybody's gone, starting out here at time point 1. So it's a devastating disease once it's spread, and we've really had no significant advances since the 1980s, when we finally realized that giving 2 or 3 chemotherapies might be better than 1. But that's the last real advance that we made. So I think that the next phase, and bladder cancer is actually a little bit behind in this, is the biological agents that are more specific at the cellular and the microscopic level that can help with chemotherapy. There's been a few trials specifically trying to target cancer cells with some of these biologic agents, and I think that's the next step for this as well. And this just basically talks about some of the targeted therapy that we use, the tyrosine kinase inhibitors with chemotherapy. Mostly preclinical, but hopefully soon to become more clinical. And that's pretty much it. I'll just conclude. Bladder cancer is a really common malignancy. Blood in the urine is the most common symptom. Non-invasive disease has a high recurrence but tends to not be lethal. The disease that goes more deeply is very lethal and requires very radical and life-altering surgery. Urinary diversion with the bowel has a high complication rate and hasn't really changed in the last 100 years. Newer regenerated urothelial constructs are on the horizon, and I think that's probably where we're heading. And unfortunately, disease that has spread beyond the bladder, we still don't do a good job of treating it. Thanks a lot. Appreciate it.
That was a whiz through bladder cancer.
Yeah, it was a little bit of a whiz.
Okay, so who has our microphone?
The test is coming up.
We've got our microphones good. Okay, so please, who has questions for Dr. Katz? I see somebody over here.
Sure.
Excellent.
Thank you very much for your presentation. I had questions about if there are studies, genomic studies, to try to characterize the genetic and profile.
Definitely. So I think that, what we are starting to call personalized medicine, so we're trying to tailor our treatment more to the individual patient rather than just based on the stage. It's really old thinking to just treat based on stage and grade, which is what I focused on here because that's kind of the basics. But looking in at patients' bladders and looking at their P53 status, their different cell cycle status, where the gene is coming from, it's happening at the laboratory level. It definitely has not made it to the clinical level yet significantly. We look at it a little bit with P53 status and try to tailor how we're going to treat them, but that's definitely something that's being done regularly. There's not a lot of specific genes that we have yet at this point, but definitely cell cycle mediators and different growth factors like vascular endothelial growth factor, epidermal growth factor. Those are things that we're targeting now with antibodies to help treat, and they're definitely helping in combination with chemotherapy. We haven't done any trials where they're being used alone yet.
I see a question over here.
Sure.
Dr. Goldberg.
Yeah. I will. Yeah, I'll repeat the question. I'm sorry. I didn't.
I have a microphone now. So are there both cancerous and non-cancerous cells that come off into the urinary fluid that you could measure externally the way one might look at rare circulating tumor cells in blood and use those kinds of microfluidic techniques?
Absolutely. So the question is what kind of cells shed off the bladder when you urinate, and can you use them to study? Unfortunately, cancerous cells are more likely to shed off. They're looser, they're not as well packed, they've lost a lot of their adhesion properties to the normal cells. So when we do a urinary specimen to look for cancer cells, that's what increases the specificity, but there are normal cells that shed off with it, and you could certainly separate them and look at them, on a cellular and microscopic level for sure. And you can also increase your yield by kind of putting some saline into the bladder and irrigating it back and forth a few times to break up the cells. So you can actually get a very high yield to do research on. We call that barbotage.
I see a question. Dr. Goldberg, right in front of you.
So the Tengion Neo-Bladder, I understand that it's not working too well because the blood supply to the bladder is very complicated.
So the question is a little bit more detail on the constructs that we're talking about, regenerated bladders. They worked great in mice initially. This was about a few years ago. And the next thing that they did was they went to kids that had neurologic disorders and that were born with very diseased bladders and that were going to potentially benefit from this the most because they had another 60, 70 years to live. They did 7 kids at Children's in Boston here actually a few years ago. Initially they did okay, but there was a lot of issues with scarring and leakage of urine around the structure because stitching to this thing, you have to stitch it to normal tissue, and it's just very firm, and the needles don't take well, and there was a lot of gaps between the stitches. So there was a lot of initial complications after the surgery, but from who I've spoken to, the patients that made it through that eventually, there's several that are doing well in the longer term. But in the short term, it was very rough. Patients were in the hospital for weeks, as opposed to like a week, which is what you'd want. Which is why I think that they stepped back and are now using the tube one, which doesn't have to hold urine as a reservoir anymore. It just has to channel it out of the body, but it still lets you avoid using that piece of intestine. And I think that that's had much more promising results because it doesn't have to act as a reservoir, and the complication rate has gone way down with that. So definitely not perfect at all by any means. They've gotten around using the bladder cells. They're able to use more pluripotential cells for this to grow, so the cancer risk has gone away. But the techniques of the scaffold, which is the really limiting factor, is what you implant the cells on for them to grow and start before you implant it back into the patient is not a very forgiving structure. And so that's, I think, where the technology, maybe the collaboration with biomedical engineering could really be fruitful.
You were talking about, I think you said sort of the part of the problem was that it was too stiff and made it hard to sew. So there's significant research to be done on figuring out how to get the mechanical properties of the bladder similar to.
Yeah, so exactly. Especially on the, because you have to sew the tubes of the kidneys to this thing so the urine can get in there. They're called the ureters. So that's a very delicate suturing technique. It's almost like sewing a blood vessel together. So it's very delicate, and they found that there's a lot of leakage around where they're sewing it into this construct. And it takes a while for the body to degrade the collagen and the polyglycolic acid, whatever the scaffold is made of. It takes months for the body to, because the theory is that the scaffold will go away and that you'll be left just with the urinary lining. But in the time it takes for that to happen is where the complications are happening.
Yes. Do you have a microphone?
With robotic surgery, I know that a lot of other countries lack of course that that's the problem with the bladder.
So the question is with the robot, which again it's a master-slave kind of robot. We don't just turn it on and say, take the bladder out. It only does what we have it do. Because we're not near the patient, is there issues with tactile feedback? And the answer is absolutely. We don't feel anything. Your eyes have to take over for your hands, essentially. So you can tell something is hard versus soft by almost the way that the graspers touch it. And if you see something kind of compress in the body, your brain says it's soft. If you see it grab something and you don't see any compression, for example, your brain tells you maybe it's harder. So I think that we've done okay because your other senses take over, but I know that there's tons of research on developing tactile feedback for these robots, whether it be a glove that you put on or some type of device to help connect you to the patient, because it's definitely a limitation. And again, this is cancer. The biggest thing is to get the cancer out completely. And so at the beginning, we were finding that what's called the margin rate, meaning that there was more cancer being left on the edges when we were doing it robotically versus when we were doing it open. And the thought was, because we can't feel around there, put your hand in, you feel a hard tumor, you know you got to go around it. Whereas with this, if you couldn't distinguish, maybe you weren't taking enough out. But that's gotten better, but more because our eyes have taken over.
Actually, I'm going to give a follow-up statement on that. You know, I had brought this up earlier. Robotic surgery for thyroid surgery is actually on hold right now because of the FDA. There was a very large group out of Korea that had been doing thousands of them, but what we found out, in fact, was that the complication rate was far higher than was probably either being reported or recognized. In doing robotic surgery for thyroid, you're tunneling in from all the way under the arm, all the way up to the neck, just to avoid an incision in the neck. Well, if any of you know anything about anatomy, there's something really important that runs there called your artery, and there's also another important thing called the brachial plexus, which controls your arm. So the rate of injury to those, which doesn't exist when you do routine thyroid surgery, was much higher than is acceptable for something that was essentially a cosmetic procedure. On the other hand, in, for example, colon surgery, when we were first starting to do just laparoscopic, not even robotic surgery, but laparoscopic surgery, Heidi Nelson ran a very large trial looking at equivalency, because there were a few reports of port site recurrences where you put the port in, there were some tumors sticking to that. And so we really had to prove that laparoscopic and robotic surgery were equivalent before we were able to move on. In the bladder, as Dr. Katz is alluding to, it's a very complex three-dimensional area. Many other organs are very close to it, and there's nothing quite like the haptic sensation, the feedback of your own fingers on that tumor. Even then, you know, Dr. Russo didn't speak about this too much earlier, but if patients have gotten, say, radiation therapy or other therapy, the healing tissue, it's very difficult to distinguish between what's healing tissue, what's cancer, what's normal thickened tissue. I mean, maybe Dr. Katz can comment on some of the technical difficulties. He alluded to it, but it's...
It's definitely, it's a major thing. I mean, they all have scar down there because when you do the resection internally in the bladder, where you scrape out that bladder, you get a huge reaction. And so it feels hard on the inside, and then when you're doing the major surgery, it feels hard there on the outside. So we don't know whether it's cancer or non-cancer. Any kind of, research that would help us distinguish that both robotically or from an open platform is something that would be huge, because this is a cancer where you really only get one chance. There's some cancers, prostate cancer, we left a little inside, we'll give you a little radiation, we'll patch you up, you'll be fine. This is one of those cancers where you really only have one chance. So you got to get it all the first time, or else it's essentially a crash course where it's not going to go well.
Dr. Wong. Speak up.
Okay, so what do you know about the molecular characteristics that Dr. Blank, for example, said for like breast cancer, it's like EGFR receptor? So what is known about the cell surface targets?
Most of what we, great question about the cell surface targets for bladder cancer. How can we potentially attack this from more of a biological way rather than just using chemotherapy, which is just going to kill rapidly dividing cells? A lot of what we know is extrapolated in our literature from kidney cancer, because kidney cancer we've known for decades is a very immunologic cancer, where we were initially treating kidney tumors with cytokine therapy like IL-2 and interferon, and then we moved into the biological agents, the VEGF receptor inhibitors, the antibodies against the different growth factors on the surface of the cell. And we've had pretty good responses to kidney cancer with that. Not complete responses, but definitely partial responses. And where we use it in the kidney is really after surgery. If it's a high-risk pathology, we'll give them some afterwards. And the side effects can be significant. So now we've basically just taken those same agents now, and we're starting to apply them to bladder. We haven't done a lot of unique research on the bladder per se. Clinically, we're trying to apply those same drugs, which should apply to most tumors, things like VEGF, platelet-derived growth factor, vascular growth factor. Those should be common to most malignancies, but we don't have the signatures for bladder cancer nearly as worked out as I would think is breast. It's probably ahead of or thyroid, they're ahead of the curve. So we're definitely behind on that, for sure.
Hi.
Yes.
Hi. A couple questions. First off, for the fluorescent marker that you used, or that you showed for picking out the cancer cells, how is that specific for the cancer cells versus the other cells? And then the other question is, can you just tell us a bit more about metastatic disease? Where do you see growths? And then ultimately, and then how do you decide on a treatment regimen? And then ultimately, why do they fail versus other cancers?
So there's a two-part question. The first was talking a little bit more about the fluorescence that we use occasionally for the diagnosis, and then second to talk about the cancer once it's already spread outside the body. What are the characteristics and what are we doing? The fluorescence, and I don't know how it got started. It turns out that the cancerous cells selectively uptake this molecule called porphyrin, which glows, essentially it fluoresces. And basically, because it selectively takes up much more of this molecule, the liquid is a precursor to that, essentially. So those cancerous cells uptake it, and they glow much more than the normal urinary cells around it. The annoying thing is that you have to instill it into the patient before, you have to put it in the bladder and then wait an hour or two and then do your diagnostic procedure. And you have to purchase all the equipment for the different wavelengths of light and the different type of scope. So it is by no means widespread. I mean, it's mostly done at a few major academic medical centers. It's done a little bit more in Europe, but because of how it's a little bit slow and it's a little bit cumbersome in terms of doing it, and a little more inconvenient to the patient, it hasn't completely caught on. There's no doubt it's better, because you catch a lot of these tumor cells at the edge that the naked eye would not have got. So if you have your scraper right there and it's glowing, you know for sure that there's no more glow at that point, so you're much better off doing it. But again, we don't do it here at BMC. I don't think anybody does it, even in the Northeast at this point. In terms of the metastatic cancer, I think you had asked where it spreads and how you kind of treat it once it spreads. It tends to be the lymph nodes, number one, so the lymph nodes in the pelvic area. And then in terms of organs, you're talking about lung, liver, bone. Those would probably be 1, 2, and 3 in that order. And what you end up basically getting worse from and dying from are the complications of it spreading to those other organs. So it spreads to the lung, and you get a big fluid collection of cancer cells, and you can't breathe well. And then you need to get a tube inserted into the chest, and then you get an infection, and then you're already immunosuppressed because of the chemotherapy. So it's not the cancer itself that really ever kills you. It's really all the treatments and all the places it's spread, and it's common to all cancers, essentially. It's what happens. So it's kind of the sequence of events, or it invades the liver, and then the liver starts to fail. Or it invades the lymph nodes, but then the lymph nodes got so big they blocked off the blood vessels. Or they, so it's basically whatever organ it hits it hard. It tends to not be the local just regrowth in the area that causes the major issue. It's wherever it goes. I assume it's similar to thyroid.
That's a follow-up. Are the cells then, is it in almost all cases, are the cells then resistant to chemotherapy?
No, so the chemotherapy does pretty good at shrinking them for a little bit. And I'd say most of the patients that go on chemotherapy for this have some shrinkage of tumor, and even a small percentage, like I wrote, maybe 10 or 20%, even have an initial complete shrinkage. But nobody, for some reason, is getting every cell because they all come back, and virtually it's 100% mortality once it's spread after about a year or two, essentially. There are some sporadic cases of very minor spread where they got the chemotherapy and it's a long-term survivor, but it's definitely the exception. And I think that's where combining it with the biological agents and trying to know more about each patient's individual cells would work. And there's a couple phase 1 trials now where we're adding the VEGF antibody to the chemotherapy for some patients, and then for the other half of the patients, they're just getting the chemotherapy. Phase 1 trial, less than 100 patients have been enrolled at this point. That's kind of where we are with bladder cancers, whereas with kidney and breast and thyroid, there are many phases ahead.
So between the two differences, the tumors that are sort of on the lining and the ones that have gone into the muscle, are they the same thing? It's just a matter of time, or are they fundamentally different?
It's a great question. So he's asking, are the less aggressive tumors, the ones that don't tend to penetrate, different, morphologically, biologically, et cetera, than the ones that are the deeper tumors? And do they tend to progress from one to the other? My experience, and I think most people's experience, is that it's two completely separate tracks. So the ones that tend to be on the lining, because it's a different genetic issue, tend to be the ones that stay on the lining. Only about 5% of the tumors that are superficial on the lining will ever progress to that different type of tumor. Whereas the ones that tend to be the aggressive ones are the ones that start out at least a little bit invasive and then can go quickly. Maybe not into the muscle right away, but into some of the layers under the lining, and then boom, they spread quickly. And again, it's completely different genetic markers, chromosome 9, different variabilities, whereas the other one has a lot of other genetic abnormalities. So it's a good research point to look at to compare the two types. Morphologically, there's a lot of similarities under the microscope. They originate from the same cell.
So actually, there's an interesting follow-up to that. So there's a concept of the adenoma to carcinoma sequence. So we take advantage of this in colon. So in colon, we know that colonoscopy and removal of polyps can avoid invasive cancer in the future. Although it looks like if you do just sigmoidoscopy, where you just go a short distance, you're missing a good bit of the distant part. So you really need to do a full colonoscopy. Any of you over 50 know about this, or 40 if you have a family history. But we know from the National Polyp Adjuvant Study that if you intervene and screen early and remove the polyps, you can avoid patients having invasive cancers in the future. I'm not certain that there certainly is not the same thing in thyroid. If you have a nodule and you leave it in, and you do biopsies and it's benign colloid nodule, then there's no evidence that leaving that nodule in progresses to becoming cancer. On the other hand, if you have a pre-existing papillary thyroid cancer and you leave it, there is a slightly higher likelihood of you going on to develop an anaplastic thyroid cancer. So, for example, if any of you know Chief Justice Rehnquist, died a couple of years ago. He had anaplastic thyroid cancer. He was actually became hoarse on the bench. He had had an existing thyroid nodule that was probably a papillary thyroid cancer, hadn't had surgery for it, and there's a big debate now because we're finding more of these centimeter and so thyroid nodules. We don't know whether to remove them or not, but there's some evidence that we should think about intervening. I think it's similar where the adenoma to carcinoma sequence is not the same in bladder cancer.
It's not.
Where they're two completely different diseases.
Yep. And but then there's that little 5 or 10% that did start out as the superficial kind and then progressed. But then I wonder, was that an undersampling, and was there a small colony of the more high-grade aggressive cells that were just never there under the microscope for the pathologist to say, but there was something there before? It's almost like none of the low-grade tumors, the ones that look really normal under the microscope, they almost never invade and get deep. It's more of the high grade. So I actually focus more on the grade than the stage because that's the biology of the tumor, what it looks like under the microscope. So, good
Any other
question.
questions? Yes.
Your radical cystectomy is on superficial ones when invaded in?
So in the rare case where you've done all the treatments.
Good question.
Oh, sorry. So the question was, do you ever do the more radical type of surgery when it hasn't gotten into the muscle yet? And the answer is yes. It's not common, but there was one type of tumor that I didn't highlight too much, which was called carcinoma in situ, which is basically, it's only in the lining, but the cells look aggressive. And that one does have the chance to spread. If you do some of your local treatments and it continues to come back, the recommendation after 2 or 3 times that it's come back is to consider to do a more radical surgery. So that's one scenario where you would consider it.
Follow up?
Do you do any functional tests on these cells to see the metastatic potential? Screening for genes?
That's a good question. I'm not sure if I'm getting exactly what he's saying.
So can you state the question?
Like phenotypic types, so like migration, putting them in like a Boyd chamber or some sort of
Right.
functional assay to see.
To check.
The question is whether we do some sort of phenotypic correlation, if we actually look to see whether the patients are going to recur or not.
I don't think we do that routinely for bladder. Do you guys do that at all on your malignancies?
No, not really.
No. I think that maybe it's a historical thing. Maybe we did way back when, and we just know that when they look like this and they're high grade and they're aggressive, we know of their invasive potential. And unfortunately, we can look at the clinical data and say that these are the patients where it starts to invade deeply and they die from this, whereas the ones that don't look like that, they don't.
There is an example. So, for example, in breast cancer, where there are genomic studies, genetic markers, where we look to see in node-negative patients, are they likely to recur? And then there are other studies going on looking to see in node-positive patients who are fully treated, whether we should treat them with tamoxifen or what else, or even like something like the Taylor-X trial, where we're trying to determine which chemotherapy would work better for patients. So in that case, we're starting to do genetic markers to determine therapy. I think Dr. Blanchard had alluded to this earlier, and I believe every patient should be on a clinical trial, even if it's just to collect tissue so we can answer some of those questions.
And that's what we're doing. We have an extensive tissue bank. Everybody that's getting these kind of surgeries now, it's being collected and frozen in the pathology department, and so we can do tissue studies once we come up with better questions to ask, essentially.
Cassandra.
I know there was a cosmetic reason for going to the thyroid and the arm, but forget the cosmetic reason, cosmetic aspect. What about doing robotic surgery directly on the neck?
I'll answer that.
Go ahead.
The issue, so she asked about, what about trying to use the robot for other parts of the body, like the thyroid, or even like an oropharyngeal cancer or something, as opposed to coming from so far away, why can't you just go right to the area? I think it's more of a space issue. So the issue is, the reason the abdomen and the lung cavity is so nice is we can blow it up with gas and get it to look like my abdomen regularly. No. So there's a lot of space for these instruments to move around in. There's no real space in the neck or in some places in the mouth where they can get enough space for the things to move around. I mean, that's
Yeah,
basically the...
I think Dr. Katz is being modest about this. You know, we have a very expensive tool, $1 million base unit, and each one of the individual tools is expensive, so you really need to justify using a tool like that. Our institution has two of them. We fight to get time on it. Dr. Katz has done a lot of these operations. We had an opportunity to train and do this in thyroid, and really most of the United States has dropped off in doing robotic thyroid surgery. I'm not aware of anyone in the Boston area who's doing it. And like I said, throw a rock and you'll hit a thyroid surgical oncologist here. So Dr. Katz and our next speaker, Dr. Fernando, really have cornered the market on the real applications for robotic surgery.
Yep.
Any other questions? All right, thank you very much.
Thanks, guys. Appreciate it.